Vanakkam. Tell me, are dislocations of the metacarpo-phalangeal joints of the fingers easy to reduce or difficult? Well, they are easy to reduce. They are also difficult to reduce. Both statements are correct. So let us see which are the dislocations which are easy to reduce and which are difficult. And we shall also see how to reduce the easy dislocations, why some dislocations are difficult to reduce, and what do we do after reducing the dislocations. But as you know, the basis of these dislocations and the subsequent treatment depends a lot on the anatomy of the metacarpo-phalangeal joint of the finger, which we shall see in this video. The entire basis of understanding the finger metacarpo-phalangeal joint dislocation and its management lies in understanding the relevant anatomy. And when learning the anatomy, we need to understand the bones and the ligaments that form the metacarpo-phalangeal joint. The metacarpo-phalangeal joint is a condyloid joint between the head of the metacarpal and the base of the proximal phalanx. The metacarpal head is typically cam-shaped, that is, it is not a regular sphere. The antero-posterior diameter is longer than the proximo-distal diameter. The base of the proximal phalanx with which it articulates contains a shallow and concave surface which is congruent with the metacarpal head. But we need to understand that the articular surface of the proximal phalanx is small when compared to the articular surface of the metacarpal head. This is because in complete flexion of the metacarpo-phalangeal joint, the proximal phalanx not only just hinges forward in flexion but moves anteriorly or translates anteriorly and then flexes. We need to understand this when trying to reduce a dislocated metacarpo-phalangeal joint. There are 5 ligamentous structures that support the metacarpo-phalangeal joint: the proper collateral ligaments, the accessory collateral ligaments, the volar plate, the dorsal capsule, and the sagittal bands. The proper collateral ligaments originate from the dorsal aspect of the metacarpal head and insert on the volar aspect of the base of the proximal phalanx. They form the primary stabilizer of the metacarpo-phalangeal joint, and in flexion of the metacarpo-phalangeal joint, they become tight or stretched. The accessory collateral ligaments originate volar to the proper collateral ligaments and insert on the volar plate, and these ligaments are tight in extension of the metacarpo-phalangeal joint. They stabilize the volar aspect of the joint. The volar plate is thick fibrocartilaginous distally and loose and membranous proximally where it is attached to the neck of the metacarpal. It forms a volar recess proximally so that the volar lip of the proximal phalanx can fit into it during full flexion of the metacarpo-phalangeal joint. This volar plate stabilizes the volar aspect of the joint. The dorsal capsule is a weak stabilizer of the dorsal aspect of the metacarpo-phalangeal joint. It is thin and loose in structure. The sagittal bands are important structures that stabilize the metacarpo-phalangeal joint by connecting the extensor tendons on the dorsal aspect and the flexor tendons on the volar aspect through the fibrous flexor sheath. They originate from the extensor hood and attach volarly to the transverse metacarpal ligament. These sagittal bands support the extrinsic tendons and secondarily support the metacarpo-phalangeal joint. Looking at the coronal view, these are the proper collateral ligaments, these the accessory collateral ligaments. This is the volar plate and the sagittal bands. Connecting the adjacent volar plates of the adjacent fingers is the deep transverse metacarpal ligament. So to summarize, when the metacarpo-phalangeal joint is an extension, the proper collateral ligaments are lax, whereas the accessory collateral ligaments are stretched. When the metacarpo-phalangeal joint is flexed, the proper collateral ligaments are stretched and the accessory collateral ligaments are lax. Hence, this position of flexion of the metacarpo-phalangeal joint is good because the proper collateral ligaments are stretched and will not go into contracture. The commonest mechanism of injury causing dislocation of the metacarpo-phalangeal joint is forced hyperextension of the digit, like falling on an outstretched hand. Though dislocation of the metacarpo-phalangeal joint can occur in any of the fingers, it is common in the marginal fingers, especially the index finger. Dislocations of the joint can be classified based on the anatomy or based on the complexity. Based on the anatomy of the dislocation, it could be a volar dislocation or a dorsal dislocation. The volar dislocation is quite rare and it occurs from a hyperflexion injury. The dorsal dislocation is quite common and it occurs from a hyperextension injury. Based on the complexity of the dislocation, it could be a simple dislocation or a subluxation, or a complex dislocation or a complete dislocation. In a simple dislocation, there is no interposition of the volar plate or the sesamoid bones, which are in relation to the volar plate. So in this dislocation, the volar plate lies draped over the head of the metacarpal bone, and the base of the proximal phalanx remains in contact at least partly with the metacarpal head. And typically we have a hyperextension of the proximal phalanx on the metacarpal head due to the direction of dislocation, and due to this hyperextension there is a mechanical flexion at the proximal interphalangeal joint. On X-ray, we will note that the proximal phalanx is perpendicular to the metacarpal shaft, or at least at an angle of about 45 to 60 degrees. This is typical of a simple dislocation, and the most important point is that this simple dislocation is reducible by closed method itself. Hyperextension or traction maneuver will convert the simple type to a complex type. In complex dislocation or complete dislocation, there is interposition of the volar plate or the sesamoids between the anterior aspect of the base of the proximal phalanx and the dorsal aspect of the head of the metacarpal bone. So what makes it complex? Can we not just reduce this dislocated proximal phalanx back to its position? No, it is not possible because the metacarpal head gets entrapped between four structures: the deep transverse metacarpal ligaments, which are distal and posterior to the metacarpal head, the flexor tendons, which are pushed to the ulnar side and posterior to the metacarpal head, not allowing them to easily come back. And we also need to remember that the flexor tendons are restricted by the A1 and A2 pulleys, which are attached to the proximal phalanx. The lumbricals, which are pushed to the radial side and behind the head of the metacarpal, and finally the superficial transverse metacarpal ligament proximal to the metacarpal head that completes the noose mechanism. This is known as the Kaplan lesion. It can occur even in an acute dislocation, but it is more commonly seen in chronic dislocations of the metacarpo-phalangeal joint, especially of the index finger. Clinically, this complex dislocation of the metacarpo-phalangeal joint can be made out by skin dimpling in the distal palmar crease, the palpable metacarpal head under the skin in the distal aspect of the palm, bayonet positioning of the proximal phalanx, which is called so because of the similarity to the bayonet knife, and on X-ray the proximal phalanx will be parallel to the metacarpal shaft. Sometimes you may have an ossified sesamoid bone in the joint space. Concomitant fractures are seen in nearly 50% of metacarpo-phalangeal joint dislocations. The important point to note in such a presentation, that is a complex dislocation of the metacarpo-phalangeal joint, is that this dislocation is irreducible by closed means. This lesion was described by Immanuel Kaplan in 1957. So the clinical features of a typical fall on outstretched hand, inability to flex the metacarpo-phalangeal joint of the finger, and a palpable rounded metacarpal head in the palm is diagnostic of the complex dislocation. Though routine X-rays will reveal a dislocation of the metacarpo-phalangeal joint, a Brewerton view is ideal. This is taken by placing the palm up and dorsum of the metacarpo-phalangeal joints against the X-ray plate with the metacarpo-phalangeal joints flexed approximately 65 degrees. The X-ray beam is tilted 15 degrees in an ulnar to radial direction. This view will show presence of osteochondral fragments which may need fixation or excision depending on the size and location. This is a classical clinical example of a complex dislocation of the metacarpo-phalangeal joint occurring in the index finger. Though clinically we can make out all the features and make a diagnosis, the X-ray will reveal certain important points which will clinch the diagnosis. Normally, a straight line drawn down the shaft of the proximal phalanx should intersect the metacarpal head. Failure of the line to intersect the head of the metacarpal indicates a complex dislocation. In addition, we will find a widened joint space. Management of the dislocation of the metacarpo-phalangeal joint of the finger can be by closed reduction or open surgical reduction. The indications for closed reduction are dorsal dislocations that are simple dislocations, but usually it may be ineffective for the index finger in which the head of the metacarpal has been trapped as described earlier. The closed reduction may also be applicable for volar dislocations. Before learning the technique of closed reduction, we need to understand what we should not do. We should never apply a traction to the finger or a hyperextension maneuver to the joint in an attempt to reduce the dislocation. These maneuvers will convert a simple dislocation into a complex dislocation because the volar plate will be pushed posteriorly and it will get trapped between the proximal phalanx and the metacarpal head. Having learnt this important point, let us understand how a closed reduction needs to be done. The first point is pain management, which can be provided by a wrist block or a regional block. The next step is to flex the wrist. This will cause relaxation of the flexor tendons. Now we need to apply pressure to the base of the proximal phalanx that is palpable on the dorsal aspect and move it distally over the head of the metacarpal and then flex it till reduction is achieved. Once the reduction is achieved, we need to apply a dorsal blocking splint. The important points here are to provide very minimal padding so that the metacarpo-phalangeal joint can be placed in 90 degrees of flexion, and the bandaging must be done in such a way that active flexion of the interphalangeal joints will be possible within the splint. This dorsal blocking splint needs to be retained for 4 weeks. Active extension exercises for the metacarpo-phalangeal joint can be started after 4 weeks. After removal of the splint, a knuckle bender splint should be used at night for 2 weeks, and after 6 weeks, passive extension of the metacarpo-phalangeal joint can be done gently. The technique of reducing a volar dislocation of the metacarpo-phalangeal joint is slightly different. Here, we need to apply direct pressure over the volar aspect of the proximal phalanx with the metacarpo-phalangeal joint in flexion. Immobilization needs to be done in 30 degrees of flexion for 2 weeks. Then start active range of movement exercises in the volar blocking splint. The indications for open reduction of a metacarpo-phalangeal joint dislocation are failure of closed reduction or instability on closed reduction or chronic metacarpo-phalangeal joint dislocations, especially the index finger. All these point to a complex dislocation of the metacarpo-phalangeal joint which can only be treated by open reduction. There are 5 important approaches for performing the open reduction. First is the dorsal approach, the dorsal percutaneous approach, the volar approach of Kaplan, the lateral approach and combined dorsal and volar approach. The dorsal approach described by Farabu has the following advantages in that there is direct exposure of the volar plate, there is no danger to the neurovascular bundle which is on the volar side, and if there is an associated fracture of the base of the proximal phalanx or head of the metacarpal, fixation can be done concomitantly. But the disadvantages of this approach are that the exposure of the volar plate is not perfect because we cannot see the attachment of the volar plate on the volar aspect of the base of the proximal phalanx. There may be delayed healing and sometimes metacarpo-phalangeal joint instability may result. The incision to this approach is usually a midline incision or an S-shaped incision to one side of the metacarpo-phalangeal joint. The extensor tendon and joint capsule are split longitudinally. Now we will be able to see the volar plate and we may be able to push the volar plate out, that is to the volar side with a freer elevator, and if that is not possible we can split it longitudinally and allow the dislocation to be reduced. The dorsal percutaneous approach is a little difficult because we need to first palpate the metacarpal dorsal surface on deep palpation. Then with a number 11 blade, soft tissue over the dorsal aspect of the metacarpal shaft is incised longitudinally till the metacarpal neck is reached. A freer elevator can be used now through the 11 blade incision to push the volar plate to the volar aspect, or we can pass in a number 11 blade again to incise the dorsally displaced volar plate. By these maneuvers, the dislocation can be reduced. The volar approach is sometimes known as the Kaplan's volar approach, which is a triple incision technique. The first incision is a skin incision that exposes the area of dislocation. It is made in the distal palmar crease proximal to the palpable heads of the metacarpals. While making the incision and deepening it, we need to make sure we don't injure the displaced neurovascular bundles. The second incision is made above the metacarpal head extending to the posterior side where it divides the volar plate and the deep transverse metacarpal ligament. This exposure can be improved by voluntarily hyperextending the metacarpo-phalangeal joint to expose the space between the proximal phalanx and the metacarpal head where the deep transverse metacarpal ligament and the volar plate are stuck. The third incision is made below the metacarpal head and this divides the superficial transverse metacarpal ligament. But just making these incisions will not reduce the dislocation of the metacarpo-phalangeal joint. We need to address the flexor tendons which are displaced posteriorly and maneuver them to the volar aspect. To achieve this, we may have to divide part of the A1 pulley over the base of the proximal phalanx. When the joint has been reduced, the flexor tendons will cover the volar aspect of the metacarpal heads and the metacarpo-phalangeal joint will be in 90-degree flexion and we will be able to palpate the metacarpal head, that is the knuckle over the index finger or whichever finger has been involved. There is one problem that can occur here. When reducing the metacarpo-phalangeal joint, that is, when flexing the proximal phalanx over the metacarpal head, this is a right flexion and correct reduction of the dislocation has been achieved. Whereas, if the correct incisions have not been made and the flexor tendons have not been released, the maneuver in flexing the proximal phalanx over the metacarpal head may be incomplete and this position may result. This is not a correct reduction and this should be avoided. The lateral approach for open reduction allows visualization of both the volar and dorsal structures, so fixation of the volar plate and fixation of the osteochondral fractures can also be done. The operative scar has a reduced risk of tendon adhesions and scar retractions. But since the joint is being approached on the lateral aspect, there is a chance of injury to the neurovascular bundle. The combined volar and dorsal approach may be necessary for late presentations, that is more than 3 weeks, when some amount of adhesions of the extensor tendons may also have occurred. There is no role for K-wire fixation of the joint after reduction unless it proves to be very unstable. Similarly, it is not necessary to repair the split in the volar plate that we had to make to reduce the dislocation. The postoperative therapy after reduction of the metacarpo-phalangeal joint is exactly as described for the closed reduction procedure. To simplify it all, if there is a dorsal dislocation of the metacarpo-phalangeal joint, we need to identify whether it is a simple dislocation or a complex dislocation, and we have seen the features of both of these. In a simple dislocation, we need to try a closed reduction, and in a complex dislocation, surgical reduction is the treatment of choice. If on closed reduction the joint is stable, we can continue with the management. If the joint is unstable, we need to take it up for a surgical reduction. The surgical reduction can be achieved by either the volar approach or the dorsal approach, which are the commonly used approaches for open reduction of the metacarpo-phalangeal joint dislocation of the finger. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about dislocations of the interphalangeal joints and also about fractures of the metacarpal bones. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery and trauma surgery. Vanakkam.